Hello and welcome to the Home of Medicine podcast, a podcast in association with the Royal College of Physicians, Edinburgh. I'm Dr. Amie Burbridge.
And I'm Dr. Ben Lovell.
Ben, I have a case for you. Are you ready?
Yes, I'm very excited.
So this was a gentleman I saw on post-take ward round, and he was in his 60s. And he presented with a 1-week history of double vision.
Oh, neurophobia kicking in. Okay.
What are your thoughts when I say double vision?
Okay. All right. I mean, what are my thoughts? My thoughts are I'm going to have to put my thinking cap on.
Yes.
This isn't going to be a quickie. This isn't going to be COPD, exacerbation, NEBs, steroids, antibiotics. Mm-hmm. So double vision, where is the problem? Is the problem in his brain? Is the problem in his extraocular muscles? Or is the problem in the nerves that supply the extraocular muscles? So is it an ophthalmoplegia? So that's broadly how I think about it. I need to be absolutely sure it's double vision. He might say double vision and he might mean something else. He might mean blurred vision. He might mean a tunnel vision. People who say double vision, you need to pin down exactly what they mean. The other thing to say is there some kind of weird refractive problem, i.e. a corneal problem or a dislocated lens or something like that. But I would try and work out if this truly is an ophthalmoplegia, and then I'll try and work out where the lesion is from central to peripheral nervous system.
Fantastic. I mean, that is, brilliant. That's probably not what I did. Because as soon as I heard double vision, I was like, oh gosh, my anxiety started. And I flipped. I've talked about this before when we have type 1 thinking and type 2 thinking. So thinking fast and thinking slow. Thinking fast is when it's pattern recognition. We've seen something before. It's on the tip of our tongue. It's in our consciousness. We know it. When it comes to neurology, double vision, I really struggle. So I went into type 2 thinking slow, thinking methodically, going back to basics and really trying to figure out what was going on. So I'll carry on.
Mm-hmm.
He said he had a 1-week history of double vision, which was present in both eyes. Oh. He described it as objects appearing 4 to 6 inches apart. And the diplopia, the double vision, resolved on covering either eye.
Okay.
He said he also had a permanent, noticeable low frontal headache all across the front of his head. He said it wasn't severe, wasn't really worried about it, and that had been present since the double vision, so for about 1 week. He actually wore glasses. And the double vision was present with and without the glasses as well. He denied cough, cold, chest pain, jaw claudication, speech changes, or any transient visual loss. Mm-hmm. He said he didn't feel nauseous, no scalp tenderness. He also reported that his left eye had a slight eyelid droop. And he'd noticed that for about a day or two. Does that change anything? Are you starting to think about anything?
Droopy eyelids. I'm thinking about Horner's syndromes. I'll be looking at pupils. I'm thinking about other signs of Horner's. Diplopia with a headache. So did he get the diplopia and now he's got a secondary headache through the eye strain essentially, or is there some kind of pathology which is causing headache and double vision, such as an ophthalmoplegic migraine? That's actually a contentious diagnosis at the moment. People say there's no such thing as ophthalmoplegic migraine, and they prefer to call it something called RPOP, which is recurrent painful ophthalmic neuropathy. Anywho, I'm getting ahead of myself. So I'm thinking about whether or not the headache is related to the double vision or whether it's a secondary effect. But I'm still trying to think about the causes of diplopia from a central sort of brain problem, starting with strokes and demyelination, working my way down to the cranial nerve nuclei and then the cranial nerves and the extraocular muscles. So I'm going to have to sit down and work that one out when I've got a bit more information.
Okay. What do you want to know? Any of the questions that you've got for me?
Ever happened before?
No.
Do you get migraines, sir?
No.
And you've never had any other nerve problems, any numbness or weakness or strange paralysis that came and went?
No, nothing at all. No.
Are you a headachy person?
Not really. No.
Okay. And what else? Any changes that you noticed to your pupil? I'll have a look myself in a minute.
I mean, to me, both of my pupils look a lot bigger.
Okay.
But I don't know. I mean, it's difficult to say, really.
All right, then. Any changes in sensation to your face or any weakness of your face?
Nothing, apart from my left eyelid is a bit droopy and my eye seems to be running a little bit more than normal.
And did this come on suddenly?
Yeah, I think so. Yeah. Just sudden onset of double vision. It doesn't feel like it's getting better or worse. It's just stayed the same.
No speech disturbances?
No.
And he's walked into the consultation room okay?
Yeah. I mean, when I saw him, it was on the post-take ward round, so I'd been seen the night before. And he was sitting on the side of the bed. Well, he was sitting in the chair at the side of the bed, dressed in his normal day clothes. Looked very well.
Okay. And the double vision's not worse towards the end of the day?
No.
When you're tired? No.
Ooh, why do you ask that?
Myasthenia gravis. It was one of the cases in my PACES exam back in 1832, whenever I sat it. So yeah, double vision worsening at the end of the day, fatigable weakness, but nothing like that, no?
No fatigability.
No history of thyroid disease, thinking of thyroid eye disease, no?
No.
Okay. And no trauma. You haven't bashed your head or hit your head or anything?
No trauma.
All right then. So in terms of history presenting complaint, I'd like to move on now. Any past medical history of note?
Diabetes.
So okay.
Type 1 diabetic for 45 years. Hypertension. Non-alcohol related fatty liver disease. And a few years ago, saw an ophthalmologist and was told that he probably had cataracts and glaucoma.
Right, but wasn't taking any eye drops.
No, so medication that he was on was insulin on a basal bolus regime, statin, bendraflumethiazide, ferrous sulfate, doxazocin, omeprazole, aspirin, lisinopril, and not allergic to anything of note.
Diabetes pinged for me there, because diabetes can cause mononeuritis multiplex. It can knock off a nerve due to microvascular sort of mini infarctions of a nerve. And I've seen diabetes cause a mononeuritis of the sixth nerve, causing an abducens palsy. So has he noticed that the diplopia is worse on horizontal, looking to the left or to the right, or is it in every direction?
To be honest, I didn't ask that question.
Fair enough. All right. But that's something I'm thinking about now.
Okay.
So if I can localize his diplopia to one direction or one nerve, then I just wondered whether this was a mononeuritis secondary to diabetes. Social history, alcohol and smoking.
Doesn't drink any alcohol, never smokes, lives with his sister, and is retired now, but used to work within the healthcare setting.
How old did you say he was?
In his 60s.
Oh, okay. Fine. And no other drugs I should know about?
No.
He's not been taking over-the-counter travel sickness medications or anything like that, and antihistamines.
I didn't ask that. Why are you thinking that?
Well, those patches you can stick on for the anti-sickness ones. If you rub them in your eye, you can get a dilated pupil and vision problems. If you sort of rub your eye afterwards. Anyway, case report stuff. Okay. I think that's enough data for me. I think it's time to examine the patient.
Okay.
What have we got?
So this is where I start to panic with neurology, because I can go through the motions. I can do the examination, PACES style neurological examination. However, when it comes to interpreting the findings, that's when I start to struggle, because I may pick up on an abnormality, but I can't immediately think what that means. I have to write it down and then really think about what that means. Observation-wise, his heart rate was 94 and regular. Blood pressure, 140/74. Temperature, 36. respirate 14, saturations 96% on room air.
Right, all normal.
All normal. So he was very chatty, very alert. You know, we were having a really good conversation. And all the time while I was chatting to him, I was sort of observing him. What I did notice on sort of direct observation is he had quite a subtle left-sided ptosis, I felt.
Yeah.
The pupils looked large. They're quite dilated, but I didn't know. I mean, I didn't know whether that was normal for him or whether that wasn't normal for him. They were equal and reactive to light. There was no relative afferent pupillary defect noted. Upper limb and lower limb, normal. Cardiovascular, normal. Respiratory, normal. Bilateral lower limb edema, quite dry skin. Now I'm going to try and tell you what I found on his examination of his eyes. Now, this is where I really struggle. So, facial nerve examination revealed a mild weakness of the left orbicularis oculi.
Wait. Slow it down.
I know.
Okay. So he had a droopy eyelid.
He had a droopy eyelid. I'm trying to be posh, exactly. So you can tell this is my type 2 thinking. I think I must have spent about an hour doing this. So he had a droopy eyelid. Sensation was intact. He could raise both of his eyebrows symmetrically.
Okay.
No problem. The right eye, he was unable to move it laterally.
Oh, okay. And the left eye was the ptosis eye, is it?
The left eye had a ptosis.
Okay.
And I thought that he couldn't abduct the left eye either.
Okay, so cannot abduct either eye.
Either eye. No obvious visual field defect. Do you know what? I actually documented, Ben, this is quite embarrassing because it makes me sound like way more intelligent than I am. I was like, oh, I think there's a subtle left inferior nasal quadrantopia.
Well, I think there is, so no one can hold you to it later.
I was like, what even is one of those? Oh, dear me. So I honestly, when I talk about this, I feel anxious. So anyway, that was my examination. And I was incredibly proud that I'd managed to do that.
Well done.
I didn't really know what it meant, to be honest.
Okay.
Anything? Any thoughts? Apart from I shouldn't see neurology patients.
Right. So when you said a right abducent nerve palsy, I thought, okay, here we go. I've got it. Is this a microvascular issue affecting the right sixth nerve? And that's why I can't abduct right eye. That explains a little bit of everything.
Yeah.
But you said bilateral abducent nerve palsies. Now that's not going to happen, is it? You're not going to have mononeuritis multiplex affecting the same cranial nerve and line site. And it doesn't explain the ptosis. Double vision and ptosis, I was initially thinking of an oculomotor nerve palsy, a third nerve palsy, which could be caused by compression, a headache. You think about an aneurysm, although you'd expect him to be extremely unwell if a posterior communicating artery aneurysm had burst. He had an intercerebral bleed, and he'd be a bit meningitic and photophobic, etc. But is something squeezing his oculomotor nerve? I can't tie that within bilateral. Oh, hang on, maybe I can. So the sixth nerve is very vulnerable to pressure because it's got the longest course. And raised intracranial pressure can cause a false localizing sign of a sixth nerve palsy, which has actually got nothing to do with the course nerves because there's high pressure in the brain. I've never heard of bilateral sixth due to high intracranial pressure, but theoretically it makes sense. Is there something compressing his oculomotor nerve leading to the ptosis and the diplopia, which is now raised into cranial pressure to the point where both six nerves have been affected and he can't abduct either eye? Ooh, he needs a CT head.
Normal.
He needs an MRI head.
Okay. Yeah.
So that's where I'd be right now. If it were me on the post-take ward round, I'd be writing that down as potential ideas. My plan would be neurology review. I think he's an MRI head, and I think I'd have to say, what's the quickest way of getting an MRI head? It's probably to admit and get one. Are you post-taking him in the morning?
I am, yes. Yeah.
Can you get same-day MRIs?
Yeah, can do.
Okay, yeah. So I think I would say post-it ward round, patient to stay, needs an MRI and a neurology review today, and then reevaluate. It would be my post-it plan. Sorry, I haven't really pinned down a diagnosis.
It's really difficult, isn't it?
But I've explained a plan. I do these things called feedback clinics, or case-based discussion clinics where resident doctors I work with can book in a time to come and bring the case to me. Some of the feedback I give to the ones who are registrars or coming up to registrar level, one of the tricks about the post-8 ward round, you think it's 90% doing the diagnosis, 10% then plan. There's actually the other way around. And the plan needs more consideration and thought, or it takes more precedence than the diagnosis at the ward round. And it took me a while to discover that as a post-taking consultant. So I do sometimes say diagnosis as yet unclear. Differential includes A, B, and C, but my plan has got to be nailed down, bulletproof and detailed, especially in the era we work in where flow and bed space is absolutely critical, and deciding what can be worked out in versus outpatient versus STEP versus, on my enhanced care unit on the ward. So I think I'd have a pretty decent plan for this guy, although I might still have prevaricated a bit on the diagnostic side, if that's okay.
And I had similar. I thought this could be diabetic, microvascular complications. I didn't word it as beautifully as you did, but I thought there was a third nerve palsy on the left and a sixth nerve palsy on the right, like a mononeuritis multiplex. I sort of ruled out giant cell arteritis because there was no scalp tenderness, no chest pain. Vasculitis, unlikely.
And by the way, that's not too bad a thought, giant cell arteritis, temporal arteritis, because that can actually present with complex ophthalmoplegias. You imagine it to be just the headache and the vision loss and the pain, but they can get ophthalmoplegia as well. So it's a good thought.
I also said, because it was bilateral, I need to rule out a posterior communicating artery aneurysm. I think that, he was incredibly well. And, but again, it's one of those things that I don't want to be caught out with. So my plan was exactly the same as yours, MRI, neurology. I also gave him an eye patch. Just we didn't have any at the time, so I gave him some sort of pads. Absolutely. And I thought, let's get neurology, ophthalmology to review, and then we'll go from there. We'll also do some of the tests. Let's look at his diabetic control, thyroid function, just see what's going on. And what was really unusual in this patient is that I saw him for 3 days running, because he was on admitting ward on post-take, and then he was on our short stay area. So actually it was really nice that I got the chance to follow him up, and that very rarely happens. So as I said, the CT head was normal. I got a CT angio to check for the aneurysm, and again, that was normal. MRI head and orbit, moderate small vessel disease, but nothing else of note.
Well, interesting. What else can cause a complex ophthalmoplegia? Wernicke's could do it. He says that alcohol. We thought about NMJ disorders and we said no. Rare mitochondrial cytopathies, nah. I said thyroid eye disease. Miller-Fisher, he's not associated with an ascending paralysis or GBS subspectrum thing. It's got no other signs at all. The third nerve nucleus and the sixth nerve nucleus, they don't sit near each other. Third nerve, I think, is midbrain, sixth nerve is pons. So if he had a patch of demyelination, for example, this is the first presentation of MS, he's got 2 lesions there. They don't sit together.
Or has he got 2 lesions? Because of my very poor examination technique with neurology, could I have misinterpreted the signs?
Okay. But the MRI is normal. So that's the end of that theory. So I'd be interested to know what neurology said here.
Okay, so neurology came along and they said, this man does not have a third cranial nerve palsy on the left. And I was like, he does? He's got a droopy eyelid. This must be a ptosis. Of course it is.
Oh, I just had an idea. Go on.
Go on. No, go on. Tell me your idea. Go on.
You know his ptosis eye? Was his eye red and inflamed and injected?
A little bit, yes.
Okay. He wasn't having a glaucoma. He didn't have glaucoma in the eye, did he? Acute glaucoma, headache, eye pain, droopy eye.
He didn't, because ophthalmologist assessed him, but that is a really good thought. Acute closed angle glaucoma, which is a medical emergency, isn't it? Yeah. No, he didn't have that.
So much for that.
So neurology documented that he had a right 6 cranial nerve palsy.
Right 6, okay.
The left side, there was nothing. They felt that the eye was normal, but they did say that, okay, we agree with you that there's something quite strange in the eye movements. And I was like, oh, okay. So I did a little bit of reading around. So we all know that when you damage the 6th nerve, the abducens nerve, it paralyzes the lateral rectal muscle and your eye can't turn outwards. Mm-hmm. And the eye drifts inwards towards the nose. The opposite eye has a full range of movement. This gentleman did have that. As the eyes work as a team, though, for example, the brain, to get an accurate representation of what you're viewing, it sort of overcompensates and it sends extra signals to the nerves, and you get Herring's law of equal innovation. Have you heard of this? No. So Herring's law of equal innovation forces the opposite eye, the good eye, to work harder. And therefore, what I was seeing potentially in the left eye was Herring's law of equal innovation. It was trying to force the good eye to work extra hard.
Do you know, I've never heard of that, and I love eponymous syndromes. I sort of collect them, and I've never heard of Herring.
Do you know, I'd not heard of it, and it was doing some reading around and having a chat to a few different people. It's one of those things that some people believe it exists and some people doesn't. But that can certainly explain maybe why, when I was looking at the left eye, it was a little bit odd.
Okay.
And it didn't quite fit. So, a consultant neurologist came down and said, this man has a bilateral 6 nerve palsy, clinically presenting only in the right eye, most likely due to moderate small vessel disease. Orthoptic assessment also said bilateral 6 nerve palsy, as well as the ophthalmologist. Now, case closed, or is it?
It's not. I always say this to you. It's not a very satisfactory diagnosis.
No, I know.
Bilateral 6, so due to small vessel disease, which is what we're saying, microvascular, probably related to hypertension and diabetes, has picked off both 6 nerve palsies at the same time.
I know.
I ain't buying it. I ain't buying that.
It's really interesting, isn't it? And that was the final diagnosis, bilateral 6 nerve palsy. A few things to talk about. So even after this diagnosis had been given by 3 people now, so ophthalmology, orthoptics, sort of myself in a little way, and neurology, there was a documentation from another member of staff to say, this gentleman has not had ESR, CRP done. He's not had a full vasculitis screen, syphilis, HIV, antiphospholipid antibodies, and ANCA screen. Please do them. Any thoughts about that?
Well, I think some of those are a good idea, because we want to do a mononeuritis screen, don't we? Or multiplex screen. Now, shall I see if I can remember them?
Yeah, yes, please.
I'm writing them down on a bit of paper. So, wards PRC. So basically, it is your vasculitis screen. Yeah. So you want to rule out polyangiitis, spondylolisthesis. You want to rule out rheumatoid. You want to rule out diabetes, but you've already got that. You want to rule out carcinomatosis. You want to rule out polyarteritis. So I think ANCA, HIV, autoimmune screen, HIV, ESR are really decent ideas.
Yeah.
I could take or leave the syphilis screen, if I'm honest with you. Yeah, I'm not very compelled to do that one. And of course, it's already got, I think his HbA1c might be useful, even though he's got diabetes, just to see how well controlled it is.
Yeah. Okay. He did have them all and they were all normal, sort of ruling out the vasculitis side of things. Now, I just want to question something here. I don't know. I felt that because 4 different teams had given him the diagnosis of microvascular complications of diabetes.
Yeah.
Was it necessary for us then to do all of these expensive blood tests?
I have thought about this because I remember when I was doing my liver job, my gastro job as an SHO, and we'd have patients come to the outpatient department with a new diagnosis of liver disease, and they'd say, "Yes, I drink 300 units of alcohol a week," and then they would still send a full liver screen, including like ceruloplasmin and alpha antitrypsin, and I'd be going, "But why?" These are expensive tests for vanishingly rare conditions, and the patient's telling me the diagnosis. They've come in and said, "Yes, I drink, and this is what's going on." And I always find it very strange them doing that. And I guess what they're trying to avoid is what we might call premature closure, which is grabbing the first diagnosis, saying that must fit. Goodbye. Let's all go home for tea. So making sure you've not missed something. So I still don't think we should be doing copper screening on people who've presented with a new liver disease, because I've never seen a Wilson's.
Nor me, actually.
No, but I think we ought to be doing. I think we ought to be doing due diligence.
Yeah. Okay.
Patients can have 2 pathologies.
They can.
Here comes dictum, and I think the patient who is being treated aggressively for complications of diabetes might have a reason to be angry if it turned out 10 years down the line they had an untreated vasculitis because we just assumed we knew the diagnosis. So I think there is some wiggle room there for me cognitively for making sure that we've excluded anything else which is treatable. Reverse.
Yeah. I think that's a really, really good and valid point. The most common diagnostic bias is premature closure.
Is it?
And we often close down. We've got a diagnosis that fits our pattern and we stop looking for other things. But as you rightly said, people can have more than one disease. And I think I am really bad at I really struggle with doing loads of investigations on people. And I think if we've got a diagnosis from 4 different people, I'm saying that I'm wrong, by the way. I don't agree with the way that I do it. I'm like, think of all that money we're spending that could be going to other people who need it. You know, we're doing all of these tests, unnecessary tests. But like you say, they might not be unnecessary. And I have been caught out when I haven't done tests and I've made assumptions and I've prematurely closed and I've missed things.
Well, think about heuristics, mental shortcut that we take.
Yeah.
For less thing, imagine don't think zebras. You know that one? So
think not donkeys. Is it donkeys? Horses? No, it's not.
Horses.
Horses.
It's not called. Don't think zebras or donkeys. If you hear hoofbeats, it's probably a horse. Horses, it's less likely to be a zebra.
Might be a donkey.
Because maybe that was different if you live in different part of the world where zebras are more common, but certainly for me in London, don't think zebras is a good rule of thumb. And a heuristic or a rule of thumb, they're a mental shortcut that we take in our clinical reasoning. And I often hear them discussed in human factors negatively, saying, heuristics leave us open to errors and it's fraught with bias, which is sort of true. But I always think about them quite positively. Heuristics are really useful mental shortcuts sometimes, and they save you a lot of extra processing and thinking by recognizing patterns and making a jump from A to B and getting a diagnosis quickly and safely. And they work most of the time. The trick comes with being open and keeping one part of your brain open to the thought that maybe this isn't what it is.
Yeah.
And I think if you come with me on my post-it ward rounds, I was on take last Friday and I went in, the night team looked like they'd been, through something pretty intense. There's about 30 patients to post-take, and I had to do it in the next 4.5 minutes or something silly. And I relied on heuristics to get me through that. Quickly, what's the diagnosis? What's the patient's story? Let me look at them. Yep, this is right. Treat with 1, 2, 3. Okay, who's the next patient? I don't have the chance to work out the hypothetical deductive model every time, which is how I started as a medical student. But let's piece all of these things together and then theoretically work out what could be the diagnosis. I have to do some leaps And I have to sort of comfort myself saying, look, if I leap in the wrong direction, the patient is in a safe place. The pattern that we have here of re-review means other intelligent people are going to see them and hopefully stop me from doing anything which might turn into harm or any myths. And a few times a year, I do discover times where my heuristic didn't work.
Yeah.
It was a zebra. I met a zebra and I thought it was a horse. If I can just keep stretching that metaphor out. But you can't go into work thinking, I must spot all the zebras today. You have to be able to rely on rule of thumbs and chances and Bayesian analysis to try and work the one thing to safety 99% of the time. And I think it's worth remembering that in the NHS, in any healthcare system, we aren't just repeatedly and constantly churning through millions of patients and encounters a week, and we are getting it right most of the time. And we do focus on the times it goes wrong because we want to learn. And sometimes those falls can be inconveniencing or tragedies to patients. But I do think that the focus we have on when things go wrong out of good intent sometimes leads you to a false sense that things go wrong all the time.
Yeah.
And we're just cracking on and getting things right in a very boring, unexciting and glamorous way. All the way from the front door of A&E to the pharmacy and the high street and all those clinical spaces in between. But to make that change, senior decision makers have to use heuristics to make very, very quick decisions.
So, yeah. I think I will say this all the time, I'm getting wiser, older, because I made what I feel was a big medical error 10 years ago. I really struggle with heuristics and the quick thinking now. And I feel like I'm slower, and I've mentioned this to you many times, than I was before, because I have to do the hypothetico-deductive reasoning on every patient, and it's ridiculous. And I can't, there's something that stops me from following my gut instinct, from using my heuristics, because I'm so scared of messing up. And I don't want to be that person who everybody goes, oh, God, you don't want to see her. She's that Amie. She's really bad. She's a terrible doctor. And I don't know. There's a lot of, I guess, psychology and some professional identity issues I've got there potentially. But
that's the human factors that affect you when you work. Hey, at least you know them. A lot of people operate not knowing what affects how they work and why they make the decisions that they make in blissful ignorance.
True. Good point. So I hope that was a interesting case for you, Ben. I think it's sparked a good discussion, actually, as to how we think, as to how we work, and certainly recapped premature closure.
I think in this case as well, there would be a patient who I would definitely recognize, say, this isn't going to be a quickie, is it? I'll say around with, I'm going to have to come back to this one. When I've switched my brain on a bit later on today. Exactly. And have a proper think and go into hypothetical deductive mode. I'm going to have to piece this from the ground up because I haven't got a pattern this fits to. I haven't got an illness fit this is matching to in my brain. Exactly. So I'm going to have to use my brain cells on this one. And I think knowing when to sit down and take your time. And that often doesn't look very exciting. It looks like me sitting at a computer, slowly tapping away, 2-finger typing. And then someone coming up and go, oh, can I help you with anything, Dr. Love? No, I've got to type this out myself because it's helping me think. And I've decided what the diagnosis is. Hopefully I'll say at the end. And sometimes I still say I don't.
Yeah. And that's a really good point, actually. Maybe, some of these cases I can get there quicker. And when I can't, I just have to take that time and say, actually, I'm going to sit down and figure this out for myself.
Yeah.
Thank you so much, Ben. As ever, you're a font of knowledge and reason. Thank you to all of our listeners out there. We are gaining subscribers, and a couple of weeks ago, we were number 5 in the medicine podcast charts in the UK, which is incredible. So I'm very proud of that.
Top 5 hits.
Yay! So please rate, review, and subscribe to the podcast. If you have any feedback, please drop me an email at amy@homeofmedicine.com. And a massive thank you to the Royal College of Edinburgh. Thanks for listening.
Bye.